Hello, and it is Tuesday, and a really great time to answer some of your questions. I got so many great things sent to me about the topic of functional seizures, so that is what we're going to dive into today. If we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist, and I am the owner and founder of Reactive Therapy and Wellness. We're in the Los Angeles area. I also just realized I'm proudly wearing my USC jacket today. I'm a professor, a clinical professor at the University of Southern California, and I get to work with amazing doctor of physical therapy students there. Probably one of my favorite things is to meet people and their families when they are looking to come to Reactive for one of our programs. And I learned so much from them. And some of the biggest questions I get are about functional seizures in those consults. And some of the biggest questions I get from clinicians are about functional seizures. I think it's something that for one, we definitely didn't get in school. There's a lot that we don't know. And honestly, there's a lot the science doesn't know about functional seizures. So there's a lot of mystery around it. They can feel very scary and uncertain. And so I think part of why I wanted to answer questions is to help empower clinicians to be able to help treat functional seizures and help patients and their families. So, by the way, you all sent me questions. In fact, I have a list of them, and they were so wonderful. I'm going to get to them over the course of the week, but I want to encourage you, please send me your questions. You can put things in the comments. People asked about preventing functional seizures or making them less experienced. What our experience as a team here at Reactive was. What about doing bottom-up regulation? How can we prevent? So that question came up a lot. We're going to talk a little bit about that today. Outcomes, prognosis with physical therapy. So we're going to talk about treatment at another day, but I wanted to, we are going to get to that. I think we need to understand the why first before we pop into treatment. Questions about dysautonomia and functional seizures. We'll talk about that today. Memory, how long they are. Responses to medication and the onset. So many wonderful questions that you all asked. So I just want to say thank you. Thank you from the bottom of my heart, because I learned so much from your questions. So let's start with what we're talking about. What is a functional seizure? And if you look at the literature, if you're looking online, you might see several different terms. So functional seizure is one of them. You might also see PNES, or psychogenic non-epileptic seizure. You might see dissociative seizure or conversion seizure. So several different terms. And I think in a way there's some misnomer there. And the jury is out. There's actually, I would say, some debate about this as well. There's a group for sure that feels that functional seizures are entirely psychogenic. And the literature actually shows there is a strong psychological component to functional seizures. But the literature also shows that they come with a traumatic brain injury. So there are other things. So I'm kind of, if I was on one part of this debate, I'm in the camp that understands a functional seizure as possibly having psychological or a psychological component contributing to the triggered state of onset of the functional seizure. But I don't think that's the whole picture. I don't mind living in the gray zone of neurology. So that's a big part of it. I don't mind that it's not one or the other, but it might be a little more complicated than that. So here at Reactive, we use the term functional seizures, and there are some groups that are kind of pushing for that as the terminology. But if you wanted to look at the research and literature, if you just look for functional seizures, you might not see everything, because a lot of the research, again, may be using the term PNES or psychogenic non-epileptic seizure. Now, what is so interesting, I recently did another dive into the literature, so I'm going to quote a lot of articles today, which, by the way, if you want links to the article, they'll be in our newsletter. You can join that at reactiveeducation.com if you're a clinician, or reactivept.com if you are a patient. So I dove into the literature, a lot of recent stuff out in just the last few years. And one study looked at the prevalence of functional seizures. These are very common. 30% of people who present to an epilepsy monitoring unit are diagnosed with a functional seizure. That, if you would have asked me 10 years ago, I would have had no idea that that was a thing in an epilepsy monitoring unit. So they're really quite common. And there's one article that I included in my post today because I really like this article. They are just as disabling as epileptic seizures. So there was an article, it was, let me get the exact title. I believe it's like functional seizures are not less important than epilepsy, and particularly talking about how disabling they can be. And I think that's just important to note. Because the management becomes very important. I think what's tricky is that the management is not with medication like it is for an epileptic seizure. The management is with therapy. So that's why I'm here, integrated therapy with that. So they're very common and very important. I would say there's something that we commonly see in folks with functional neurologic disorders. So they may have functional weakness and functional seizures, or functional dystonia and functional seizures, very common coexisting in a functional neurologic disorder. Now, what are they exactly? And I think this is an area that we keep needing to explore and understand a little better, to be honest. But there's a wonderful book, and I will put a link in our newsletter. It is so good, and the whole entire book is free. Let me give you the name of it because you can also search for it. It's called Treatment of Functional Seizures in Children and Adolescents, a Mind-Body Manual for Health Professionals. I love this book. The first author is Blanche Savage, and it is a whole manual. And what I love is they have a really nice, simple definition of what a functional seizure is. And I just loved it. So I was going to read it to you here. Functional seizures are sudden, time-limited episodes of neural network dysregulation. So let's break that down. They're sudden, okay? So they come on suddenly. They're time limited, meaning they're over a certain course of time. They're episodic, so they're episodes. And neural network dysregulation. What does that really mean? And you know, if you've heard us talk a lot about functional neurologic disorders, we talk about it being a connection issue in the nervous system. Some components of where different parts of the brain are connecting, talking, communicating with each other becomes dysregulated. And they use the term neural network, and I like that because there have been imaging studies in functional seizures that look at what are some of those network changes that might be occurring. What is important here is if we want to distinguish this from an epileptic seizure, because an epileptic seizure involves electrical changes in particular areas of the brain, and they show up on an EEG. These neural network dysregulation in a functional seizure does not show up on an EEG as an electrical change. So they are positively diagnosed. So functional seizures are positively diagnosed. The gold standard is a video EEG so that you can actually see the movement patterns. They're different in a functional seizure versus an epileptic seizure. So you look for those differences in a video EEG, and then you look for a change in the electrical activity in the EEG. So that's a distinction. And as Ethnicity Garden says, that's a really good description. I loved it too. And again, I highly, highly recommend this book. And the whole book is totally free to download. Again, it's called Treatment of Functional Seizures in Children and Adolescents, a Mind-Body Manual for Health Professionals. Now, it is intended for a pediatric population, but I got to tell you, I've learned so much from their research and the work that they've put into the book. It's really, really good. So what might that functional seizure look like? So we're talking about it being this neural network dysregulation, and that can look a couple of different ways. It can actually look like just a total shutdown for that person. Spaced out look on their face, a dissociated feeling for that person. This is kind of where that dissociative seizure terminology came in initially with functional seizures. And honestly, I do think there are a portion of functional seizures that are truly dissociative seizures. Dissociative means dissociating. You disassociate from the body. And that can occur for many reasons. Sometimes that occurs due to pain. It's a way the brain actually protects us and helps us cope through a really painful experience. So it could be due to physical pain. It also could be due to emotional pain. I don't know about you, but I definitely experienced this 2 years ago. I lost my mom, and I had episodes of just being totally disconnected from my body. The grief, I lost my mom very suddenly, unexpected, really traumatic, and the grief was overwhelming. And so I'm not saying I experienced a dissociative seizure, but a dissociation is something that can and does commonly happen in humans as a way of protecting and coping through something. And that can become a dissociative seizure. I'm getting somebody, can you link to where to find this book? Yes. So I always put the links of everything I talk about into my newsletter. So I'll put the link there. It is from the place that I downloaded it. Let me pull it up. It's the Australian group, Australian Academic Press, is where I downloaded it. But I will put the link in the newsletter. Such a good book. So I want to talk a little bit then about what is happening in the brain. And there have been a few studies in functional seizures, just like in functional neurologic disorders, looking at what are some of the brain changes that might occur. What are these neural network dysregulation? Now, these are resting state functional MRI. So it's not necessarily happening when a seizure is occurring. Although there was one case study that I found where they did actually look at functional MRI during a seizure. And that was really interesting, but just a case study. So we can't extrapolate that to everybody. But in the studies, so I'm gonna read you one of them here. They've seen both structural changes and functional connection changes. So 2 studies have found so far an increased connectivity at baseline between the areas of the brain responsible for emotional control and movement. Emotional processing. I gotta get all my words here. Executive control and movement. So those 3 areas of the brain: emotion processing, executive control, and movement. So this is really important because the other type of functional seizure that we see, so I talked about the dissociative kind of shutdown seizure. The other is a jerking, clonic, myoclonic, tremoring type of activity. And you can imagine then if there's a neural network dysregulation, and it includes on a functional MRI disruptions in emotional processing, executive functioning, and movement, that might manifest itself in extra movement, involuntary. It is totally involuntary. So that's another piece of functional seizures. This is not faking it. This is not the person voluntarily jerking their body or clutching their hands or tightening their eyes. It's entirely involuntary. So the other thing, there was another study looking at people with functional seizures, and they had abnormal activity, abnormal circuitry. Again, this is in functional MRI, not your typical diagnostic MRI, and these are only in research studies. They involved the emotional areas, the subcortical areas, and those areas of sensory motor control. So again, these are actually really similar to the findings in functional neurologic disorders as a whole. So there's a lot of overlaps in these brain areas that are involved. I want to answer a couple of questions here. I will share the link in our newsletter, for where to find the book. And Ethnicity Garden says, yes, when the pain is too much, my body just powers down. Yes. And you know what? That is that's coping. That would be a natural response to do, right? So thank you for sharing that. Somebody else asked, does it look like T2 hyperintensities on an MRI? Great question. It does not. So functional neurologic disorders, functional seizures do not show up on hyperintensities on an MRI. That's because connective issue problems don't show up on MRI. They show up on functional MRI, but functional MRI is not diagnostic. So at this point, and this is where I would say, I think our technology is behind us. I don't know when this is going to come, but at some point, potentially we will have a way to look at these functional connectivity changes on imaging in a better way outside of just research. It's not diagnostic at all. Somebody else asked, will you post this for rewatching? We always post our videos after we're done, so I will post this. Somebody else is saying, I don't get seizures at the moment. What are the chances of having seizures? So if you're not having seizures, this talk, and especially with functional neurologic disorders, most people with functional neurologic disorders don't have functional seizures. So I have not seen it develop into that for folks. So it's something I want to reassure you that it's not inevitable that people with functional neurologic disorders get functional seizures. So I want to reassure you of that. Typically, actually, what I've seen more often is that the functional seizure is the first functional symptom. Not all of the time. I've also seen in people with really severe CRPS or pain syndromes that, again, they may actually develop a functional seizure as a part of a functional neurologic disorder. And again, it might be what many people call a dissociative seizure, which I would almost say is a subtype of a functional seizure. Now, one thing that has come up a lot in the literature about kind of why these occur is the psychological piece. Most people with functional seizures do report a psychological history, a history of abuse or trauma. Not everybody. So this doesn't mean it's going to happen for everybody with a history of abuse or trauma. It also doesn't mean that's the only cause of a functional seizure, but it's one of the causes. So that is something that I think is really important to assess and address. That's not my specialty. I'm a physical therapist, so I'm going to assess and address the sensory components or the autonomic components or the motor control components or a pain component of these pieces. But this is why being on an integrated team is really important to me, because I'm not actually equipped to address those other pieces, and they're important pieces of the puzzle, and I don't want to ignore them. So that's why we've got a great team. Now, this brings me, I want to bring up, by the way, there was one other article. Let me get you the name, because this was really great. Oh, shoot. I don't know if I will put a link to it. But it was looking at functional seizures after traumatic brain injury and finding them to be very common. And so on one hand, we might see functional seizures in somebody with a history of trauma. On the other hand, we might see functional seizures with somebody with a history of a brain injury. So very different pieces, and we just need to look at all the components that might be contributing. So let's talk about that when it comes to triggers, because several people ask me, how can these be prevented? And I think for a lot of us in understanding neurologic disorders and how we're going to go about treating them, it's understanding how they might have started for the person in the first place. And as one person is commenting here, I've had 6 concussions in 12 years and F&D seizures last year. So there does appear to be some sort of connection in the potential of development of functional seizures after brain injury. Not everybody gets them. And some people get epileptic seizures after brain injury. And some people get epileptic seizures and functional seizures after brain injury. But I think what's important here is to really kind of go, oh, well, that is curious. Somebody has a brain injury, a disruption of their neural networks, and they end up with this dysregulation. There's something going on there. And I think we can restore it, especially when we can get down to the bottom of some of these, the triggering pieces. So let's talk about these. Somebody had mentioned dysautonomia, so let me go there first. And this is why, again, we think of the pie chart with different components that kind of get to the underlying pieces of a neurologic disorder and symptoms. So autonomic is one of those pieces of the pie. And I find can often be a really big piece of the pie when it comes to functional seizures, and can be a trigger. So we work with people with POTS, for example, postural orthostatic tachycardic syndrome, and having a flare in those symptoms can be a contributing factor to a functional seizure. We can see when a person has a high heart rate. That might be a contributing factor, or low blood pressure, or an episode of syncope. So syncope, like a vasovagal type syncope or an episode of fainting, is not a functional seizure, but we could see that be a trigger for one. So autonomic stressors, and autonomic components can be interrelated with other pieces. So they can be interrelated with the sensory system. So we can see that people might be overloaded sensory-wise, sound, vision, smells, etc. And that can be part of their seizure, the functional seizure trigger. So the autonomic piece of the pie, the sensory piece of this pie, those two are interrelated. And they're both interrelated to the psychosocial piece of the pie. So psychological stressors, going back to school, tests at school. Now, this doesn't mean that everybody taking tests is going to have a functional seizure, but those things all can build up overall nervous system dysregulation. And so I mentioned pain, fatigue, illness. So somebody else asked me about medication too, introducing new medications. This doesn't mean we need to be hyper aware and uber vigilant and ultra tracking all of these things. It just might mean that all of these pieces might come together to be triggering an episode for a person. So medication, illness, so viral illnesses, flu, things like this. Why I got my flu shot, getting my boosters, like all of those things can protect us, right? Against some of these triggering factors. And what's triggering for one person might not be triggering at all for another person. For some people, just a medical visit can be dysregulating, particularly if they've gone to medical visits before and been told they were making things up or that they were faking it or that this was all in their head. It brings a whole lot of stress to the nervous system to go into an appointment that way. So that particular level of stress can also be part of what contributes to the nervous system dysregulation. And on the other end of this, even extreme levels of excitement can trigger a seizure, because that also can be nervous system dysregulation. Much less common. I would say that's not something I hear as much. I think what I hear more, and I see more in our clients, is this accumulation. So this leads to the last piece that I want to share about. And I put this in the post earlier today, which was a picture of our river runneth over. This picture, I don't use it all of the time, but it is one of my favorites. Chelsea Richardson, our FND program director, Mike Studer, amazing neuro PT and colleague friend of mine, and Carly Lockala, another one of my fellow USC professors and an amazing clinician in Oregon. We put together this river runneth over picture and analogy to talk about functional neurologic disorders for a presentation back in 2019. Is that right? Has it been that long? And it just really resonated with me and with our team, and we've been using it. I think it actually fits even better for functional seizures. So you can picture this. It is a waterfall, mountains, and a river, right? So this really resonates to me because I love nature. I love being outside. And up at the top, we've got storm clouds. So these storm clouds are things that might contribute to nervous system dysregulation. If you think of the river as kind of what is our nervous system capacity, those rain clouds would keep contributing to it. So they can be things like sleep deprivation. That could be a really big one for functional seizures. Sleep deprivation, pain, a illness or an infection, a psychological stressor, an autonomic dysregulation, sensory overload, all of those rain clouds raining into the river. Our nervous system only has so much capacity. So at some point, it's going to overflow. And that overflow, that neural network dysregulation may show up as a functional seizure. It may show up as functional weakness. It might show up as tremors or dystonia. But that is the overflow. What I love about the river runneth over, and by the way, again, if you're wanting the visual of it, it's in the post I posted earlier today. When you work with a rehab team, you are digging out that nervous system. You are creating more space. You're creating safety. You're building sandbags along the riverbank so they hold more capacity. You understand yourself better as a person experiencing the pain, the seizures, the symptoms that you're experiencing, so that after a day of all of these loud sounds, add on to that my sleep deprivation, add on to that I haven't eaten for 3 hours, add on to this, those things are going to dysregulate. And I'm going to end up with symptoms. And so we're going to talk about that later this week. To talk about treatment. What do we do from a treatment standpoint? Huge role of a whole integrated team in functional seizures. We've got to understand all the pieces of the pie, all of the different triggering pieces, and put that back together with the person, not for the person, with the person, because the person brings the most wisdom about their body and their symptoms. I believe the person's the center and is the most knowledgeable. So we bring those together to put into treatment. What I want to tell you, while functional seizures are very common, while functional seizures are extremely disabling, while they are very, very scary for the person and the people around them, I have seen across the board in working with people, and the literature shows this as well, is people can get better and people can be seizure free too. And I think that's pretty exciting. So more to come when we talk about treatment. I want to thank you all so much for your great questions that led to this video. And why I'm going to do another live one on the treatment, because you asked great treatment questions too. And I'm just going to double check if there's any other questions, comments here before I sign up. Somebody else said, my teen began having dissociative seizures after TBI. Yeah. So there is a study, and I'm going to, let me just look really quick. I jumped into so many studies, and I lost track of the first author on that one, but it looks like that is actually fairly common. We see that as well, and it actually kind of makes sense because the brain is in a dysregulated state after a brain injury. There was even a really interesting abstract from neuro-oncology that looked at functional seizures in brain tumor patients, and finding they did it was a small sample, but it was like 25% of their very small sample of people with brain tumors and brain tumor removal developed functional seizures. And honestly, some of these studies just really make me think like, wow, I might have missed some of this when I was a young therapist, not understanding seizures, but not understanding functional seizures. So I will put that article, I'm not seeing it in my list right here, but I will put that article in our newsletter. If you're a clinician, sign up at reactiveeducation.com. If you're a patient or a family member, sign up at reactivept.com, and I'll send out all those articles. So many good ones this week, honestly. And Ethnicity Garden says, that's how I got FND after a TBI. And you're not alone. That is, you know what? It's not in the literature as common, but I will say when I meet somebody with FND and I talk to them I always ask about other things, concussions, migraine, are they autistic? Do they have sensory processing differences when they were younger? Hypermobility? there are themes that come up, and TBI and concussion is definitely one of them. So I will keep listening to you all and all of your great questions. Thank you again. I will keep learning, and I'll keep sharing what we're doing here at Reactive. So thank you so much again for joining me live tonight. I will catch you again this week for another one to talk about functional seizure treatment. And be sure to get on our newsletter, and I'll send you, actually I send all of these videos. They get uploaded to YouTube, and we put them in our newsletter, and all the resources, articles, everything that we share. So I hope you'll grab it there, and I will see you later. Have a good night.